call upon the next speaker, Dr. Neha Hemendra Shah.
So my topic is, I'm Dr. Ajay Dudani. So my topic is any single piece foldable lens can be converted into a transscleral tuck lens. So PCR and vitreous loss always comes unannounced. Anterior vitrectomy is done, but if there's a very poor posterior capsular support where you can't put the lens on the rexes, you can't always keep a battery of IOLs ready as a follow-up in this patient, especially with odd power IOLs like AC IOL, iris claw, 3-piece. Hence the need for a method where any single piece IOL can be converted into a scleral tuck lens. The principle is creating a transscleral plug on an haptic for scleral support. So you can deliver to your patients what you promised, a premium IOL, trifocals, EDOFs. So this is the inspiration which I got for this thought which I had in my mind. The Carvalhale lens, which has got a transscleral plug which holds the IOL in position in patients where there is deficient posterior capsule, and the CMT Flex lens which is there available in the market. So this is the worst kind of lens which you have a rent where you can't put this on the sulcus. The only extra thing is you need either a 40, 50 or a 60 Prolene suture in this case. So this is how the lens is fashioned. It's a single piece lens with a Yamanization of the haptic, like you create like a dumbbell sort of a 50 Prolene outside the eye rather than doing it inside. So you have a lens which you have created on the table when you have that complication, and you can create these two bulbs like that here. And one bulb will hold the haptic inside the eye, and the other one is exteriorized to give a support in the transscleral support this is. So this is a surgical technique. You mark the limbus at 3 and 9 o'clock, limited peritomy. You make an angled incision of the sclerotomy with a 23 gauge MVR blade. So you create a tunnel where you can tuck that dumbbell inside post-op. So you have a flanged, the IOL which you have created, you can inject it over the iris because the PC is absent. Then each transscleral plug is exteriorized with a 23 gauge max grip vitreous forceps. And the laxity is adjusted by further dumbbellizing by using extra cautery. And then you can co-opt the peritomy with diathermy. So this is how one of the first cases I did when I was learning this thing. This was the 3-piece IOL which has gone into the vitreous after 10 years of surgery because the Prolene haptics do degenerate over a period of years. And this is the, one second, sorry. So this is how we created the IOL, you know. So this is the video which is showing that. So this is the 3-piece IOL here, as you can see, with the transscleral suture IOL, and this is how you create the dumbbell. And then this IOL is injected into the anterior chamber.
They had the strongest.
So this is just showing you a brief video. So once you've created that IOL, this is how we exteriorize the haptic here. Can you see that? It will come out. And similarly on the other side you could do that. And this can be further. So the other side you can similarly do that.
Go away.
Usually I use a AC maintainer or a vitreous infusion, and then you can further create the dumbbell and push it inside the scleral tunnel which you have created. So this is how it looks post-operatively. So what I have thought that with the industry assistance, if you could create a banding sort of a thing, you could create a device like that where you could have it in your OT, and any lens you can feed this sort of this device here, the transscleral plug device, and convert your IOL into a transscleral plug IOL. Thank you very much for your patience here.
The IOL, what you retrieved from the vitreous,
Yes, sir.
it seemed to have broken haptic.
Yeah, sir.
at some part.
Yeah, sir. In that I didn't reuse the same IOL. We used the separate
Okay.
IOLs.
Okay,
was
I
just to
thought
show
you
you.
used the same IOL.
No, sir. We used the separate IOLs.
Okay.
Yes, sir.
Question?
Thank you.